Alrighty, let's go ahead and get started. Thanks y'all for joining us. We are very excited to have our biannual hospital medicine CPC today, uh, led by Dr. Yusuf Saklawi, who serves as the chair of our division's hospital medicine CPC team. So he will take it from here for further introductions and a great discussion. Thank you, Dr. Saklawi.
Thank you, Annie. Hi, everyone. Very happy to be here. Excited for another CPC session. Very happy and excited to introduce Dr. Caliendo. Eric was my co-resident here at Emory. He did his medical school at Weill Cornell in New York. Then he moved to Atlanta, did his residency here at Emory, and follows a career trajectory in academic medicine and is passionate about clinical reasoning. He was actually a case presenter here on Grand Rounds a few years ago when he was a resident, and now he's the discussant today. In his free time, he loves movies and spends as much time as possible going to independent cinemas around the city. So, Eric, do you want to say a word?
I will say that I usually end up at one of the AMCs because there's just so many more of them. One that is right down the road for me. So it's an aspirational goal to spend more time at the Plaza or Terra.
Love it. So at the end of the session, you can ask Eric for movie recommendations and questions about medicine. I would also love to introduce Dr. Giancarlo Licitra. He also goes by GC. Giancarlo is a medicine resident here at Emory. He's a PGY3 resident. He is passionate about cardiology. He does research about congenital and structural heart disease, and his research is focused on outcomes in patients with the Fontan procedure and complex transcatheter interventions. Outside of medicine, he enjoys spending time with his family, discovering new restaurants, and staying active outdoors. GC, did you want to say a word as well?
Hey everyone, nice to see everyone. I was a medical student when Eric was an intern in the MICU on the same service, so full circle here.
Yeah, thank you, GC, for presenting. We do have a surprise discussant that I will introduce shortly in the session. We do also have a poll everywhere, which we might or might not use depending on how the flow of the session goes, but this is it. Or you can go to polleverywhere.com/Yusuf and you can log in. And Giancarlo, whenever you're ready, you can go ahead and get started.
Sure thing. I'll pull up my slides here. All right. So I have sort of organized here by aliquot. There's going to be 5 aliquots to the case before the diagnosis is revealed. So without further ado, I'll jump right in. So first aliquot here, the case presentation we have is a 22-year-old, otherwise healthy young female. She's coming in. She had a syncopal episode at the airport. Essentially, the story is that she had 2 weeks of progressive weight loss. She had some decreased oral intake, wasn't feeling well. This was 2 weeks prior to her syncopal episode, and then she had 2 days of chest pain, intermittent chest pain, fatigue, fever, and chills in the 2 days leading up to her presentation. And then
GC, sorry, we just don't see your screen.
Oh,
I do.
Gotcha. Is that better?
Yeah, you're good.
And the chest pain was described as a pulling sensation, no other associated symptoms with the chest pain, non-exertional. And so just diving in a little bit more of her history, no other past medical history, as I mentioned before. She was on no medications at this time, no other remarkable family history. Social history is that she, had graduated from college and recently moved to Atlanta, spent most of her life in Missouri. No allergies, and that's the majority of the HPI. We can open up for discussion.
Great. Can everyone see my screen? Awesome. So I don't have any financial disclosures. So this chief complaint syncope, it's one of the the great chief complaints. There's a lot to talk about. The definition of syncope is a transient loss of consciousness from temporary decrease in blood flow to the brain. There are three buckets for how I think about syncope. The first one is a decreased cardiac output. This can be from valvular issues or left ventricular outflow obstruction from most classically HOCM, especially in this young female. Pericardial effusion with tamponade physiology, PE, anything that would decrease blood flow through the vascular, the central vasculature. Carotid stenosis, decrease in flow to the brain, and arrhythmias, either both bradycardia and tachycardia with poor perfusion. Next is the orthostatic bucket. This can be from intravascular decreased intravascular volume, either from GI or GU losses or large volume hemorrhaging, as well as medications such as diuretics. And then our third bucket is decreased vascular resistance, will prevent blood from getting to our organs, especially the brain. Classically is a vasovagal response, overactive parasympathetic response, adrenal insufficiency, again, a vagal irritation, either from mediastinal masses or ictal syncope. Classically, distributive shock is not usually included in syncope, as this is less likely a transient vascular resistance decrease. And then we also have to think about the mimics of syncope, like seizure or hyperglycemia. Just want to also highlight the clinical problem solvers schemas, which are great that helped give a framework for this. But let's also look at the other HPI that was presented here. We have this subacute onset of decreased oral intake and weight loss, as well as more acute symptoms of non-exertional chest pain, fevers, and chills. Now, both of these subacute and acute symptoms can map onto the cardiac and orthostatic causes, but what we can roll out at this time, we're not going to make any grand differentials right now, but this patient reportedly is not taking any medications, did not seem to have any hypoglycemic symptoms of shaking or increased warmth sensation, and we don't have really any classic symptoms of seizure. But again, we're not going to make any big calls just yet, put my nickel down. So I'm going to be at the end of each aliquot kind of just recapping what we have. So this is a 22-year-old woman, no significant past medical history or medications. She has a subacute onset of low oral intake and weight loss, and presenting with a syncopal episode that was associated more acutely with fevers, chills, and chest pain. Now, we need to think about what are our next steps. So in syncope, history is most important. This is the way that we're going to not only make our diagnosis, but help the other diagnostic, narrow our diagnostic steps. So we need some situational information. For example, was it positional? Was it a sudden blackout? Is there any bleeding? That would be an obvious question for hemorrhagic. The positional nature would be more an orthostatic. Sudden blackout, maybe while sitting, would be classically cardiac. And then we have to ask about prodromal symptoms. Also interested to hear about where the patient's poor intake is driven. Are they having dysphagia? Are they having early satiety, persistent nausea? This could, this could raise our suspicion for a GI or a esophageal issue. The family history and social history don't have any remarkable findings, but of note, we should make sure we ask about any sudden cardiac death or history of familial syncope, and then our good social history with alcohol use or use of stimulants. Our physical exam should, really start at the top with the vital signs, especially orthostatics. This is, hopefully obtained prior to fluids. And then our physical exam will pay attention to the HENT exam, looking for conjunctival pallor, auscultating for and palpating for arrhythmias, thinking about our abdominal exam that could point to a mass preventing oral intake, edema, or hyperpigmentation that could point us towards Addison's disease. We'll get the basic workup to start with, given that this is a pretty broad differential. Want to make sure we're ruling out electrolyte abnormalities, anemia, getting cardiac enzymes because of her symptoms of chest pain, and then we can get some basic inflammatory markers given her subjective fevers, TSH to rule out any arrhythmogenic hyperthyroidism, and then a cortisol level for our adrenal insufficiency. And then most importantly, to get our EKG to calculate a Canadian syncope risk score and see if there's any obvious arrhythmias, and then a chest X-ray for her chest pain, and keeping a CT chest on the differential. With that, I think GC, you can take over for the next aliquot.
The second aliquot of information here. So getting into some of the pertinent exam findings for her vital signs. So no fever, heart rates, borderline tachycardia, ranging from the 90s up to the 110s. Blood pressure, sort of also borderline, as low as 92/60 and up to 107/67. Breathing relatively comfortably 17 times a minute and 100% on room air. And most notably, the BMI is 15. Other aspects of the exam, relatively unremarkable. She wasn't in any acute distress, but overall thin appearing. Cardiac lung exam was within normal limits. HENT exam is normal. The abdominal exam was normal. No rash is noted on a thorough skin examination. Also a thorough neurologic exam that was normal. And to jump into some labs and imaging, in initial imaging. So notably on her CBC, her hemoglobin was low at 9.7 with an MCV of 89. White blood cell count was 7.6 in normal differential. Platelet count 373. Going into the chemistries here, also unremarkable. Bicarbs 26, potassium 4, creatinine renal function is stable at 0.4. And then I also have here, there we go. LFTs unremarkable, T-Billy 0.3, troponin at presentation was negative. She did have a mildly elevated D-dimer. Her urinalysis at this time showed 2+ blood, and when looked under microscopy, 30 RBCs noted. Chest X-ray on initial evaluation was negative, and then they did bilateral lower extremity Dopplers as well that were negative. And so we can go to a discussion here.
Great. So just to look over this new set of data, most notably in the vitals, she's underweight considerably at BMI 15 and slightly tachycardic. Her exam was really notable for some negatives rather than any positive findings. Her mucous membranes were moist. She had no conjunctival pallor, no murmurs or heart rhythm irregularities, no abdominal tenderness or edema. Now her labs do reveal, that's probably the most revealing portion of this aliquot. She's anemic. She has low albumin, an elevated D-dimer, which will be important in our putting together this case, and then hematuria as well. The other imaging, notably, we don't have an EKG in this patient with syncope. That would be very helpful moving forward. But there's some notable negatives. No obvious abnormalities in chest X-ray, no lower extremity DVT, and no carotid stenosis. I'm not sure if maybe that was included in the information that I got. Maybe not shared here, but it's good to know. The prolonged, we have to wonder how long she's not had good oral intake with that hypoalbuminemia and that her being so underweight. Let's take a quick detour into talking about hematuria in this patient. Classically defined as more than 3 RBCs in a UA, and we're not going to talk about hemoglobinuria because we know that she has 30 RBCs. We'll break it down to glomerular and non-glomerular causes. Classically, glomerular would be, from a small vessel disease in terms of, bleeding at the site of blood filtration and reabsorption in the kidney at the action site. Dysmorphic RBCs can be seen in both, but more often and classically associated with glomerular causes. RBC casts, by contrast, would only be seen in glomerular diseases. And classically, the glomerular causes would be post-infectious and autoimmune, and the biopsy would most likely be the way to give us a definitive diagnosis. Whereas in the non-glomerular category, we have more disruption of large structures within the urothelial tract. UTI in this young female would be the most common, but a CPC about complicated cystitis would likely be a first. We have to think about our patient population. Malignancy probably be less likely. But other causes such as like a Wilms tumor are less malignant, neoplasm, but we're not getting any history of GU or GI symptoms, back pain, which would make trauma and stones less likely. And these non-glomerular causes would most likely be diagnosed on imaging or just thorough history. And we also have to rule out menses as a contaminant here. Now, this is a short summary of the data we've collected so far. We've got more subacutely decreased PO intake, probably more than the 2 weeks, or there is a more inflammatory process that is driving a low weight, more acutely non-exertional chest pain, fevers and chills, and then our most important objective data being the tachycardia, low BMI, anemia, hematuria, and elevated dimer. Now, thinking about chest pain, if we were going to put together a post-Simonis diagnosis at this time, we can think about a chest mass that could cause compressive symptoms on the esophagus, not want to make her eat, have some chest pain. But I think I'm not ready to make that diagnosis just yet. But let's paint back to our chief complaint. We still haven't gotten a full description of the syncopal event, which really prevents us from ruling out much here. As we stated, history is the most important aspect of our workup. But we have not heard of any obvious prodrome, which makes vasovagal syncope a lot lower on differential. And the information that I received, the carotid ultrasound was negative. And then we can only really work with our other associated symptoms, which for now are poor PO intake, which leaves orthostasis on the menu. And then we still haven't gotten the orthosag vitals, but in a young person, we need to have a high suspicion for primary cardiac abnormalities like HOCM and arrhythmias like Brugada. Hemorrhagic is certainly lower on the differential with only mild anemia. We need some more information. We don't have really any information about bleeding, but hemoglobin of 9.7 doesn't definitively rule out a hemodynamically significant bleed prior to a decrease in concentration, but this is very low given our presentation here. I'm going to go out on a limb, pun intended, potentially, that the subjective fevers, hypoalbuminemia, chest pain could all point to an inflammatory state leading to VTE and PE. Negative lower extremity Dopplers does not rule out traveling thrombus to the pulmonary vasculature. So our run.
But sounds like Eric's differential here is PE pulmonary hypertension, hypovolemic and primary cardiac disorders. And I think we can run through aliquot GC until Eric comes back. And then in the meantime, we'll get more information about the patient and we'll run through it together.
Sure thing. Here we are. So moving on to the next aliquot. So more imaging, as Eric was mentioning, I think we're all anticipating the CT chest, which showed a 4.5 centimeter subcarinal mass that was encasing the pulmonary artery and had mass effect, causing high-grade stenosis of the artery. There was also some mediastinal lymphadenopathy noted on the CT chest. As a result, she got an MRI brain and a full body PET that didn't show any evidence of metastasis, nothing else lighting up in the body. And then at this time, she got a transthoracic echo where she had an ejection fraction of 55% and had a moderate pericardial effusion without any evidence of tamponade. And here's the imaging of the CT chest. As you can see, the subcarinal mass causing this stenosis of the pulmonary artery there. I don't know if Eric's back on, but certainly worth a discussion.
Sorry, I am back here. I am
Okay.
back. Sorry. I can share my screen. Okay, wonderful. Let me just show. Can everyone see my screen? Sorry about that. I think it must be the weather. I apologize, everybody. So what you didn't get to see was I did ask for a CT chest. So that was the big, along with some lab work. But yes, so this 4.5 centimeter subcarinal mass was quite a surprise to me. I was not expecting to have a mass causing pulmonary stenosis as our cause of syncope. Notable that the MRI brain and PET scan were negative for metastases as well. So that will help narrow our differential for a subcarinal mass. So just a recap, the patient had coming in with syncope and generalized fevers, weight loss, and chest pain coming in with found to have pulmonary artery stenosis from a mediastinal mass. Now, this is the mediastinum we're talking about, so we're not thinking about the terrible T's of our anterior mediastinal masses. It's less exciting, I think, than the anterior, and less endocrinologic. But what we have to think about here in the middle mediastinum is there's a lot of lymph nodes. So we have to think about lymphoma, pulmonary infections, which can lead to reactive lymphadenopathy, as well as other reactive lymphadenopathy, metastatic lymphadenopathy from cancers and other from classically of the lung and other draining lymph nodes, and then a slew of autoimmune conditions. Other less exciting causes of mediastinal masses would be benign cystic tumors of all the primary tissues in that area, bronchogenic, enteric, and pericardial. And then in this area, we can also have masses seen on imaging that are actually just vascular abnormalities like aneurysms or rings. Now, because we have information collected during this aliquot, including a PET scan that was negative, our suspicion for our metastatic process is pretty low. We don't see we don't often see invasion of vascular structures as a very benign of tumors. So I'm going to go ahead and say that our benign cystic tumors are very low on our differential. And then our imaging does not reveal vascular abnormalities or aneurysms, and rings are pretty low on our differential. So If we're going to focus on, a lymphatic process or lymph node as this mass that's encasing that pulmonary artery, we're going to think about our patient and her presenting symptoms. She has weight loss, fevers, and we can convince ourselves that these are B symptoms. And that was so what's driving lymphoma being at the top of my differential for her. Age and generalized inflammatory symptoms. We're going to certainly keep the slew of autoimmune causes, sarcoidosis, rheumatoid nodules, lupus. That's certainly going to be on the differential. And then, geographically, the patient's at risk for both histoplasma and blastomyces. We would more likely see some pulmonary involvement, some sort of increased metabolic activity on the PET scan, but it is classically can give you this mediastinal mass. So I think, given that we don't have any other targets to a biopsy for this mass, and we don't, and we're waiting on other laboratory results. I do think that we have a very large mass that we could potentially biopsy, probably with the subcarinal location. It's amenable to endobronchial biopsy. We would, if I were the hospitalist taking care of this patient, I would certainly discuss with CT surgery up front, given the encasement of the pulmonary arteries. She's high risk for intubation. Should we try resection? But that is just a thought I had as a generalist. And then other diagnostic steps, echocardiogram, peripheral flow cytometry, and LDH to work up lymphoma, and then our autoimmune workup, ANA, RF, CCP, ACE level for our sarcoid and lupus, rheumatoid nodules. ANCA, less common cause of pulmonary, extrapulmonary nodules, but can be seen in vasculitis. And then HIV would be really helpful in understanding if this patient's at risk for opportunistic infections. And then, as I said before, at risk for blastomyces and histoplasma. And now, Yusuf, do we have time? Sorry about my internet right now, but do we have time for a poll everywhere?
Yeah, so if anybody wants to participate, feel free to vote either on the website or you can text there. Thank you, Eric, for the excellent discussion. I'm glad the patient was not diagnosed with the UTI because of the hematuria and then discharged on 5 days of Bactrim. So we have some votes coming in. Yeah, so very dispersed votes. See malignancy at a third, infection at a third, autoimmune at a third almost, and 6% voted for congenital, maybe because of GC's research interest in congenital heart disease. Giancarlo, back to you.
All right. So moving forward with the case to aliquot number 4, what we have are some case updates here. So as Eric had mentioned, some advanced diagnostics that he had ordered were completed. Bronchoscopy with endobronchial biopsy. This was actually done twice, which I'll get into in just a moment, as well as a video-assisted thoracoscopic surgery VATS procedure with mediastinal biopsy of the mass and then the surrounding lymphadenopathy within the mediastinum as well. And basically across the board, what was found was necrotizing granulomatous inflammation with completely negative cytology and negative bacterial, fungal, and AFB cultures. Here's a picture of the necrotizing granuloma from one of the mediastinal lymph nodes for all our budding pathologists out there. So happy to hear what you think. What are your thoughts, Eric, on this?
Yeah, this was, I'm glad that we got a lot of tissue that, and what we're seeing here is necrotizing granulomatous inflammation. It's not a definitive diagnosis. It, opens up a differential, but also narrows it to help us, and I'll get into the more information on the next slide. But this other information that we've gotten is really helpful in narrowing our differential for necrotizing granulomas, negative cytology, negative bacterial, fungal, and AFBs. While our TTE, maybe this was in a prior aliquot, but it did show a moderate pericardial effusion. Well, knowing that there is a pericardial effusion is certainly helpful clinically. We have to monitor this patient for tamponade, but its presence does not definitively rule in or rule out. It's likely reactive to the process and that is going on in the surrounding lymph nodes. Globally, the most common cause of constricted pericarditis would be TB, but I think this patient's at lower risk for that right now. Now, necrotizing granulomas are classically, infectious. We have our suppurative necrotizing granulomas, but there can be necrotic regions within, given a certain duration and degree of growth of these granulomas. In the right patient population, we could probably narrow to infectious causes, but without any striking evidence that the patient is at risk for those, we'll talk about our infectious causes first to convince ourselves that this probably isn't the driver. So we have classically necrotizing granulomatous disease with mycobacterial diseases, endemic fungi, and then our zoonotics, Bartonella, Brucella, and then syphilis are great, a great masquerader. Malignant granulomatous granulomas can be from our lymphomas and metastatic carcinomas or carcinomas themselves. And then our autoimmune granulomatous disease, classically sarcoidosis, is at the top of that list. But lupus and rheumatoid nodules, in the name granulomatosis with polyangiitis, as well as Church-Strauss eosinophilic granulomatosis with polyangiitis, histiocytic disorders, and then granulomas forming around foreign bodies. As I said before, in this patient, we have a lot less concern for the necrotizing granuloma being caused by infectious causes, especially with negative AFBs. The fact that our cytology is negative, it definitely brings lymphoma and carcinoma lower on our differential. We're not seeing any atypical or malignant cells. We have several different biopsy samples, so I'm going to forge ahead and trust the pathology reports. This patient's not in the right population for histiocytic, Langerhans, usually presents a little earlier, and then we don't see any evidence of foreign bodies in our pathology report. I'll say there's one caveat: AFB cultures obviously can take weeks to mature. I'm not sure the duration which we were saying that they were negative. Bringing it back to what brought this patient into the hospital. Now we have pathology, we have all this workup. Let's see if we can interpret her findings in the context of some of her presenting symptoms. We have, we can't forget the hematuria, this elevated D-dimer, and this findings of inflammation and potential other organ involvement. Even though we didn't had a PET scan, we had the whole body, but there may have been something else at play here. So thinking about our systemic, maybe systemic inflammatory diseases, things that are affecting other organ systems. Sarcoid is going to be at the top of my differential at this time. It's the most common cause of granulomatous disease in the general population. I agree with the folks that said that malignancy and infections are at the top of the list, but as we saw from our multiple negative cultures and cytology, we don't have it doesn't bear out in the data, so we're going to go with sarcoid at the top, and then we have granulomatosis with polyangiitis. Again, granuloma is in the name. It can also, cause, it can also affect the kidney, bringing back that hematuria. Although 90% of cases do involve nasal sinus or ear involvement. So in my opinion, can't be at the top of the differential right now. And then EGPA would most likely have a current patient with a history of asthma or recurrent sinusitis. And then I know that the fungal cultures were negative, but given that our only geographic infectious agent would be the dimorphic fungi, I'm going to leave this dimorphic fungi on there because we're classically necrotizing granulomas are in the purview of the infectious infectious bucket. So we're going to keep that on for ourselves. So right now we have our 22-year-old with potentially systemic inflammatory symptoms with a subchorial mass and necrotizing granulomas causing stenosis of the pulmonary artery. What are we going to do next? As stated previously, the presence of granulomas on biopsy does not clinch the diagnosis. We have to look in the clinical context and to really come to a consensus. We should comb through our data, reconsider other historical elements. We will be getting, other exposure histories, sexual and social history. We definitely want, we haven't gotten our ANA, ANCA at this time, with our concern for GPA, ACE with our concern for sarcoid. And then we're still hoping to get HIV to see if she's at a higher risk for these more opportunistic or, disseminated endemic fungal infections. And then, to really rule out our zoonotic diseases, thinking about Brucella and Toxoplasma serum antibodies, because Brucella can certainly be difficult to isolate in culture. With the presence of moderate pericardial effusion, we can, don't think we need pericardial sampling of all that great tissue that we got, but certainly a patient that we want to keep a close eye on and even think about empiric treatment at this time to ensure that pericardial inflammation doesn't worsen. At this time, with a lot of the negative cultures, my bet would be that steroids would be our empiric treatment.
Yeah, thank you, Eric, for the excellent discussion. I encourage everyone to vote or put in the chat what would you do next, or think about what you would do next. Let's see, we have some good distribution here. We have a majority thinking this could be like a granulosa polyangiitis, maybe 2/3 and 1/3 thinking this is sarcoid, or almost an even split. So excited to hear more, GC, and the listeners. If you have any questions or anything you wanted to ask from Giancarlo, you can put it in the chat as well. And almost even split.
Great. So going back to our case here. So our final aliquot number 5 here, a little bit more case progression. So something we had noticed after the second bronchoscopy, so the patient was giving periprocedural dexamethasone, basically to help prevent any complications from the procedure involved with the airway. And we noted the patient had subjective clinical improvement over the next 24 to 48 hours. So it was hypothesized that there was maybe some sort of immune response, decreased immune response in the setting of these steroids. And there was a high clinical suspicion at the time for histoplasmosis, considering her environmental exposure. And considering how sick she was, the decision was made to treat with empiric prednisone and itraconazole, presumably for histoplasmosis. At this time, there was more urine studies performed that showed over 24-hour urine proteinuria as well as microscopic hematuria, as we had kind of mentioned before. We looked closely at the urine. It showed many RBCs. and they were dysmorphic as well. And then sort of towards later on in the hospitalization, the patient had developed some dermatologic manifestations. This included delayed pressure urticaria that had started to resolve with the steroids. Some like fleeting erythematous pruritic hives after maybe some questionable grass exposure after leaving the hospital for a little bit, but then also had this intermittent rash appear on the lower extremities that was described as macular and non-blanching. And here's some pictures. This was taken. So happy to hear the next part of the discussion. The next aliquot will reveal the diagnosis.
Great. The diagnostic journey continues. Yes. So we have our urine sediment analysis. So this is, we'll break down this aliquot, starting with the urine, which I was very excited to see. We're seeing now over 60%. I did not have that in my aliquot. 60% dysmorphic RBCs. With over 25% in a per high power field has a specificity of over 96%, with a positive predictive value of 94% for glomerular nephritis. So that is certainly an interesting finding. And then we're also seeing a treatment response to prednisone. I'll also put in, in my aliquot, I didn't realize that the dexamethasone was given first with that rapid improvement. So that is certainly a telling bit of information, data. So now we're really thinking about our small vessel disease, right, with our involvement of the glomerulus, and then another manifestation of small vessel pathology with our macular non-blanching purpura. We're getting into our diseases that cause inflammation, cause platelets and inflammation within platelet aggregation, inflammation within small vessels on the skin. And at the top of that list for me would be vasculitis, and then our thrombocytopenia and DIC and pressure urticaria, something I'm less familiar with, but and looking into it, seems most often it's idiopathic and drug related, but vasculitis is also a known cause. So we are, certainly in the realm of our small vessel vasculitis rising to the top of our differential. And certainly at risk for anchoring, but in knowing that we have a granulomatous process, we can come back to our differential and start to narrow a little bit more. As I stated before, over here I've X'd out EGPA in this patient, not likely a cause of in a patient without a history of asthma, does not have as classically as many extra pulmonary manifestations or extra sinus manifestations. And then I'm going to say that our zoonotics typically do not cause these very classic findings for other small vessel disease, and certainly cannot fully rule out these other autoimmune, probably rheumatoid we could probably take out of there. But interesting. Sorry. Our recap, we have these patient with necrotizing granulomas and glomerular, I'm going to say glomerular nephritis with the proteinuria. I didn't have that information. Granulomas with glomerular nephritis and non-blanching purpura for me is always going to be vasculitis first. So that is our top of our final diagnosis differential. And I will go through the diagnostic reasoning for each of these points. And we're going to keep sarcoid on the differential, disseminated sarcoid, as well as disseminated histoplasma as the rounding out our infectious causes. So why granulomatosis with polyangiitis is at the top is because we have our classic findings of granulomas with vasculitis and glomerulonephritis, and we have a steroid or a pretty good response to steroids. Cons if you don't have classic sinus or lung parenchymal involvement. Again, I said before, the 90% of the time there is some sinus or ear involvement, which you did not get a history of. Sarcoidosis, we have pulmonary lymph node granulomas, we have systemic inflammation. Sarcoid can affect every organ, and there is a response to steroids. We don't have classic hypercalcemia. There's a subcarinal location as opposed to hilar, and we don't often see these types of skin lesions in sarcoidosis. And then for disseminated histoplasmosis, again, these are necrotizing granulomas, which is most classic in our histoplasma infections. And then there was also a response to steroids and azoles, more importantly. This patient, we haven't gotten a history of immunocompromise. We've had those negative fungal cultures, and does not often affect the skin and kidneys. So those are the cons for histoplasmosis as well. So what do we do next? I do think that getting a biopsy of another organ, my goal would be for the kidney. Those can give us the most specific histopathologic findings, which would be the pauciimmune concentric glomerulonephritis. And we could also get a less invasive skin biopsy, though. It can have some less specific findings, like leukocytoclastic vasculitis, which can be seen in other disorders. And we will also test fungal elements in these biopsy samples as well. The suspicion is pretty low, and then we are still waiting on that ANCA. That can help guide us towards a diagnosis, even though it will not clinch it better than a biopsy of a second organ. The ANCA that we would be looking for would be C ANCA in this population, and then there's some other, especially with the finding of glomerulonephritis, we want to think about any sort of hypocomplementemia that would be causing isolated glomerulonephritis outside of the granulomatous process. If we're going to use Hickam stictum here. All right, so that was the final. I'll bring up my final diagnosis differential again, but I guess we want to do one more pull everywhere.
Yeah, it's okay to hold off this one, Eric. Thank you so much for the excellent discussion. Yeah, and the teaching that you delivered. Giancarlo, take us home, and then we can hear from the expert.
Sure thing. So just to wrap things up here. So as we've been kind of awaiting here, ANCA serologies came back. C-ANCA was positive, high immunofixation titers 1 to 320. Serine proteinase 3 was positive as well, with elevated titers as well as a rheumatoid factor. And so kind of bringing things together, we have a glomerulonephritis, evidence of glomerulonephritis. We have the rash that's characteristic of a typical vasculitis, and then serology is positive for C-ANCA and serine proteinase 3 in the setting of this necrotizing granulomatous inflammation and this subcarinal mass. So we were able to make a primary diagnosis of granulomatosis with polyangiitis, GPA. So excellent job, Eric. So just to kind of also round things out with the patient's course. So at this point, the itraconazole, after just being briefly started, was discontinued. She was initiated on pulse steroids and eventually given rituximab. There was clinical improvement after all of her steroids, as well as resolution of the pericardial effusion on follow-up imaging. And then as an outpatient, she had imaging of the mediastinum that showed decreased size of that mediastinal mass and less encasement of that pulmonary artery. So that's the case. Well done, Eric.
Thank you so much, Giancarlo. It's my pleasure to introduce Dr. Susanna John. Dr. John is an assistant professor in the Division of Rheumatology. She serves as the co-director of the Myositis Specialized Clinic, and she's dedicated to advancing the care of patients with autoimmune inflammatory myopathies. In addition to her leadership in the myositis clinic, her interests include optimizing early diagnosis, management, and long-term care for patients with complex autoimmune diseases. Dr. John, look forward to learning from you.
Thank you for the introduction and the excellent case presentation. It makes it easy for me to transition to this disease. Let me put my screen. All right, can you see? Okay. So this is a summary of the case. I think there are several buzzwords, factors that should make you think about granulomatosis with polyangiitis. Vasculitis is a group of disease that cause inflammation of blood vessels. It's a systemic disease that can affect multiple organs, and oftentimes it's a challenging clinical picture. And if not diagnosed early, it can be life-threatening. But an even bigger challenge today is for me to talk about this big disease in less than 10 minutes. So we'll see how that goes. All right. So there are different types of vasculitides, and they are differentiated by the size of the blood vessel they affect. So they include the large vessel, medium vessel, and small vessel vasculitis. The small vessel disease is what we are focusing on. These are divided into two groups. Those where the pathologist can find immune complexes on tissue biopsies. That's what we have here, the cryoglobulinic vasculitis, IgA. And then you have the other group where there are no immune complexes. And this group is also known as pauci-immune and have another name, ANCA-associated vasculitis, because all of them are associated with the anti-neutrophil cytoplasmic antibody. So there are three different diseases in this category. You have MPA, microscopic polyangiitis. Then you have GPA, granulomatosis with polyangiitis, which is today's case, and EGPA, eosinophilic granulomatosis with polyangiitis. So the picture to the right on the top, you see immunofluorescence of a cytoplasmic pattern of staining for ANCA, that is c-ANCA, and this is strongly associated with antibodies to what we call leukocyte proteinase 3. So c-ANCA, PR3, they go together. And then at the bottom, you have a perinuclear pattern of staining for ANCA, p-ANCA, and this is seen with antibodies to several different proteins, but mostly anti-myeloperoxidase antibody or anti-MPO. So p-ANCA and MPO. So, what's the frequency of these antibodies in our diseases when you do the labs? So ANCA is the main diagnostic serologic test. These are antibodies directed against the granule components of the neutrophils and are implicated in the disease pathogenesis. So PR3 ANCA or c-ANCA is most frequently associated with GPA, while MPO ANCA, p-ANCA predominates in microscopic polyangiitis or MPA. But also you can see a good amount of, you can see these antibodies in several cases of drug-induced vasculitis also. So let's keep in mind that ANCA, they are by no way completely specific for GPA or ANCA vasculitis, because they can be found in many other inflammatory conditions, such as inflammatory bowel disease, infections, malignancy, and many times drug reactions too. Okay, so what do we know about the pathogenesis of GPA? There are two phases. One is the chronic phase and that's where the granulomas are being formed. Granulomas, by definition, they contain giant cells, lots of giant cells, and they are formed by a mixture of T cells and activated macrophages. So we believe that these giant cells engulf dead neutrophils, which can then lead to an inflammatory vasculitic phase. And this cycle just keeps going on. So looking at this slide, focus in the center, you have ANCA-associated vasculitis placed right in the center with arrows pointing to the three main organ systems that they can affect: kidney, lung, respiratory system, upper and lower, and then skin. So here what I want to point out is when you look at the kidneys, what is the characteristic lesion that you will see? So this shows a glomerulus with features of necrotizing crescentic glomerular nephritis. And this is very typical for ANCA vasculitis. What is more non-specific is just mild mesangial proliferation. That's non-specific. Another histologic mimic, if you see things like glomerular sclerosis, interstitial fibrosis, tubular atrophy, these are all things that you can find in chronic kidney disease. So you can't really make a diagnosis of ANCA vasculitis with these. And then this is just a normal glomerulus for comparison. Moving to the other part, the respiratory system. Here, the characteristic lesion is a dense inflammatory infiltrate with granulomatous features. This is very typical for GPA. And then other non-specific findings, you may have just mild inflammation or edema, and that's not specific for vasculitis. And a lot of inflammatory, other infectious processes can also resemble these mild inflammatory findings. Okay, and then in the skin, the characteristic lesion here, this is leukocytoclastic vasculitis. It shows more of neutrophil infiltration and fibrinoid necrosis of the vessel walls. Non-specific findings can be just mild perivascular inflammation. So this slide, my intention is to visually summarize this wide spectrum of histopathological findings in ANCA vasculitis across the key organ systems. So if you see these characteristic lesions and the pathologist calls it out, then they are highly suggestive of ANCA vasculitis. But if you see more of the non-specific findings and mimics, then you definitely have to think through more differential diagnosis. Okay, so these are some imaging findings of what we would expect. I did see in the chat someone mentioned about not, being surprised that a big lung mass could be associated with small vessel vasculitis. So this might help clarify that. So this picture A shows a perforation of the posterior nasal cartilage, thickening of the nasal cavity, which is one big part of GPA. But this patient that was presented did not have any ENT signs or symptoms, which makes it even more challenging to come to the diagnosis. Picture B shows peripheral bronchovascular reticulation with some bronchiectasis, and it's all more in the right lung. This C shows an ultrasound of enlarged kidneys, which you can find. In picture D, diffuse bilateral consolidations here, some ground glass nodularity, and this is consistent more with alveolar hemorrhage. And then over here, you have two large cavitary lesions in the left upper lobe and a small nodule in the right upper lobe. You can also have parotid gland enlargement and abscess formation. This is a slide just to kind of compare the clinical features of GPA and microscopic polyangiitis. There's a lot of overlap, but there are some differentiating factors. So fever, weight loss, myalgia, arthralgia, all of your constitutional symptoms can be similar across the board for both diseases. But the ENT involvement is the major differentiator. So when you see GPA, very common to see destructive ENT lesions. Think chronic sinusitis, nasal septal perforation, saddle nose deformity. These kind of lesions are rare in MPA. With lung involvement, both have it, but the patterns can differ. In GPA, you have more of nodules or cavitary lesions, and then also infiltrates alveolar hemorrhage. But for microscopic polyangiitis, you see more of diffuse alveolar hemorrhage and interstitial lung disease. Renal disease is frequent and severe in both diseases, and most of the time it's rapidly progressive glomerulonephritis. Skin and peripheral nerve involvement can occur in both. Look for palpable purpura, nodules, ulcers, mononeuritis multiplex. Other organ systems are less commonly involved. So when you see destructive ENT disease, think GPA. If you see severe renal and pulmonary capillaritis without granulomas or without any destructive ENT disease, then think MPA, microscopic polyangiitis. All right. Some pictures here to show the different presenting features and different phases, active versus chronic disease. So the first picture, A, shows nasal septal perforation. This you can see by shining a light through to the right nostril, and then the light streams through the opposite side because there is this septal perforation. And this patient's nose is no longer inflamed, but that nasal septal perforation can remain as a permanent damage from previously active disease. Picture B shows you the typical saddle nose deformity. Picture C shows scleral thinning. This is a patient who's probably had necrotizing scleritis, and over a period of time, that scleral thinning is evident by the appearance of that bluish underlying choroid. And also, you can see the saddle form deformity at the nose. D, you have subglottic stenosis. And you can see a lot of scarring, a lot of erythema, which means this is probably an active phase of the disease. Many times, these patients need to be evaluated by ENT and will need manual dilatation with endoscopy and glucocorticoid injections locally. Two different types of skin pictures here. Picture E shows cutaneous necrotizing vasculitis in a patient with PR3 ANCA or C ANCA associated vasculitis. And picture F shows, in E, the difference is you see more of a blistering skin disease, hemorrhagic skin disease, necrosis, purpura, all of that. But then if you look at F, this is more of leukocytoclastic vasculitis because, and there's not a lot of blistering here, and it's widespread purpuric rash. And this is a picture of a patient who has MPO ANCA vasculitis, so MPA. Another picture here, this patient has a large palatal perforation. You can see the midline of the hard palate, and then the surrounding mucosa looks erythematous, ulcerated, inflamed. There is evidence of necrosis and tissue destruction extending towards the nasal cavity there. Crusting is seen around the nasal vestibula. So oral lesions can be the initial presentation for GPA, And it is crucial to recognize these findings before it becomes more systemic. This is a patient with GPA where you can see more of orbital and sinonasal involvement. There is severe periorbital inflammation with conjunctival and scleral redness. That lower eyelid is almost gone due to tissue destruction and necrosis. You can see the saddle nose deformity here. And then some of the eye symptoms can be proptosis, diplopia, vision loss in these patients. The CT scan imaging on the right side just shows the bony destruction of the nasal septum, the medial orbital wall, and soft tissue density extending back into the orbits. This is called strawberry gingivitis, if you've heard the term before. It's more of a diffuse erythematous, friable enlargement of the gingiva. You see it in the maxillary and mandibular arches. This, it looks like a granular hyperplastic surface with areas of ulceration, and it's called strawberry gingivitis because of the bright red pebbly texture which resembles the surface of a strawberry. So that's another one. So in 2022, the American College of Rheumatology and EULAR, the European League, came together and decided to have a scoring system to classify GPA and help people diagnose it. This scoring system works after you have diagnosed somebody with small or medium vessel vasculitis. So that's step number one. And then you got to exclude the mimics, all the infections that were talked about today, malignancy, definitely rule it out. And then you can use these points where almost all the clinical characteristic features of GPA we talked about have a lot of strong points: lung nodules, the serology, positive C ANCA PR3. There is also a negative weighting for eosinophilia and anti-MPO antibodies. So that helps to differentiate between eGPA and MPA. You need a score of 5 or more to make that diagnosis. And this is my very last slide, just a brief thing about treatment. Of course, you need to put these people on, start patients on steroids, but the emphasis overall guidelines is rituximab as the first line of induction if you're dealing with severe disease, which is what this patient got. Rituximab is an anti-CD20 monoclonal antibody. It causes prolonged B cell depletion and thus reduces autoantibody production. Cyclophosphamide can be used as an alternative, but we're mostly leaning towards rituximab. Rituximab is also preferred for severe diseases in maintenance immunosuppression because it seems to have a superior relapse prevention rate. But for non-severe GPA, you can use methotrexate or mycophenolate as alternatives to rituximab. There's something new, not new, it's being used a little bit more recently compared to before, and that's avacopan. It is a selective complement 5A receptor antagonist, and it blocks C5A mediated neutrophil activation and chemotaxis, thereby reducing the vascular inflammation in ANCA vasculitis. It also seems to help in quickly tapering off glucocorticoids when avacopan is added to rituximab in the induction phase. Plasma exchange, what about that? It's not really routinely used for alveolar hemorrhage. You can consider it, but that's about plasma exchange. How long are people going to be on immunosuppressive therapy for maintenance? Usually 24 to 48 months, but this varies. It's individual case-by-case basis depending on their relapse risk and all the other medical comorbidities and shared decision making. So that's most of what I have for today. If there are any questions, I'm happy to answer.
We are
Thank you
unfortunately
so much.
on time, so I don't know that we have any questions at this point, but I wanted to jump in and thank all of our speakers for an incredible discussion. I think many of us learned lots of things. Congrats to Dr. Caliendo for being correct. Those of us who know him are not at all surprised. And thanks to everyone else for being here. Two quick reminders. We have moved to an opt-in calendar invite system. So if you would like future calendar invites for grand rounds, just click yes on that list. And then next week, we are very excited to host Dr. Nate Gross, who's an Emory School of Medicine grad and the founder of Doximity. He'll be joining us for a grand rounds. It is not going to be recorded. And will not be available for CME because of his relationship with Doximity, but it will be on AI and health. And so I think we will have a really great session next week. I hope to see many of you there. All right. Thanks, y'all, for being here. Have a great rest of your afternoon. All right. Bye, y'all.